before we embark about the skin in patients of COVID, equally important, especially for me sitting here and dealing with the healthcare workers also, the skin of the healthcare workers. And please forgive me for sharing photos which are not actually my patients or who have not sought consultation from me. This is a common photograph from the net. All my patients had the same feeling not to share their photographs. So I don't have any photograph of my patient, rather my as healthcare workers who had come to me seeking some advice for their difficulties faced during the posting in the COVID hospital, our own RCH or elsewhere also. So the healthcare workers, the problems that they face is of variable types. I have put urticaria angioedema as at the top because this is the one which have troubled our RCH the most. One of our senior residents went through that episode of urticaria, which was severe enough that she needed steroids and ultimately had to be withdrawn from the services. It was bordering to angioedema. The second and the most common one is the effect due to high humidity. As we are all aware that once we put on the PPE kit, we sweat a lot. And along with the running of the ACs in most of the COVID centers, especially the isolation ICUs, the humidity continues to give a lot of trouble. And then the third important factor is the pressure effect, which is very much required for the proper application of the various PPE kits onto our body. These pressure effects lead to initial erythema, which is very common. Most of us have seen, some of us have also experienced. And this erythema, it not taken care of earlier because of any reason, sometimes inevitable, there is skin breakdown, abrasion. That leads to further deterioration of ulceration, necrosis, and maybe even gangrene if it is not interrupted in time. When we consider the areas that are commonly affected, at the top of the list is the mask area disease. Other than those inflicted because of the pressure, we also come across acneiform eruptions, tinea faciae, not tinea cruris, tinea faciae, contact dermatitis to the various materials which make the PPE kit, and also seborrheic dermatitis, the scalp primarily, and also around the upper half of the body. Second most important site are the hands. Once again, contact dermatitis starting from sanitizers to the material of the PPE kit and gloves. Eczema, paronychia are also common. Predisposing factors, whatever may be, sanitizers keep on adding to them. The feet, especially those who put on the full PPE kit for full 6 to 8 hours, they have intertrigo and eczema. And the natural body folds, again because of high humidity, they develop tinea, cruris, intertrigo, and also eczema. The last one, as you might notice, are the flame burns. These are very interesting ones. Not so much appreciated because it's a not so common one, but once we apply the sanitizer, it stays there for some time and it is highly inflammable. Within that time limit, if the person comes in contact with the flame, there is every chance that he is going to undergo burn injuries. So sanitizer should not be used in any place where there is a chance of having a flame. And after the usage of sanitizer, one should wait till it dries off completely before going into a kitchen or a similar place. This is with respect to those healthcare workers who are suffering from skin problems in this COVID times. For them, this is more, you can say, as inevitable, not much preventable. One point that needs to be highlighted is before putting on PPE kits, one should moisturize the skin to reduce the effects. And after the PPE kit removal, when they come back, sanitization is done. Once again, they should try to use a moisturizer and hydrate themselves properly. Hydrated skin repairs very fast and undergoes damages very slowly or to the minimal extent. Now coming back to the important topic of skin in COVID-19 patients. Like many other organ systems, skin can be affected by inflammatory or thrombotic events. These are the two important aspects of the current COVID that is going on. And to describe the skin manifestations, we go back to the phases which I have taken the privilege of dividing into 4 phases. The active viral phase, which is the initial one, and which usually manifests with fever, dry cough, shortness of breath, or less commonly GI disturbances with the smell and taste. And the second one, which happens in about 2nd to 3rd week time, which is immune dysregulation phase. This is the one which we say as the cytokine storm, which is being revised again and again, bradykinin storm, and this has more serious implications. This phase, virus doesn't play a major role. It is the immune system of our own body which is doing it. Then we have the recovery phase or convalescence. And the 4th is the sequelae. This is the long-term effect which we are now beginning to see. So in the active viral phase, what are the skin presentations that we see clinically? Exantheme, what we see outside, and enantheme, which we see in the mucous membrane, especially the oral cavity. Of the exanthemes, the 3 broadly clinical patterns which we see are the urticaria, erythematous rash, and vesicular rash. Urticaria. This is one of our patients. We had just 2 or 3 lesions of urticaria, and this photograph was snapped by one of the residents probably and sent to me for a quick opinion. These urticaria in these patients or a similar condition, this is yet another from our own home isolation patient, do not differ much from the urticaria that we see in all other cases. So this may be due to the infection, the virus, it may be due to the treatment being given for this particular thing, or it may be a totally independent thing which may have a similar time frame during the period of infection. Any food item or anything in the environment which has given rise to urticaria. Erythematous rash, we can have a maculopapular rash, morbilliform, follicular rash, or erythema multiforme. And these are all patterns which are clinically definable, and their presentation does not give much significance to what is the severity or the stage of the disease. This is also seen during the acute viral phase, and these patterns are seen in many other viral conditions. These rashes may be because of the inflammatory chemical mediators of inflammation, which is in circulation. It may be just to dissipate the heat that has given a reddish flush to the body, or it may be because of predilection for certain structures of the hair or the skin appendages, or the hair, which has given rise to this pattern. First of all, we see the maculopapular rash. This is once again a very common rash seen with most viral conditions, infections. And here we can see that it does not follow any pattern. It can be there anywhere in the body. Similarly is the morbilliform, a measles-like rash, resembles measles, but very often they are not measles, although it is very difficult to establish a diagnosis. But presuming that the vaccination, which is traceable in the history, has been done, and the other features not coinciding, we consider this as a morbilliform rash. And the third pattern which we commonly seen is the perifollicular rash. This is more often seen on the back and also on the thighs. In this particular condition, the rash, erythematous rash, remains limited to the hair follicle or the surrounding area. Here we see another case. This was a very interesting case. Just to bring to your notice that I have circled in blue a particular thing which looked like a vesicle when first sent to me. So my initial provisional diagnosis was heading towards vesicle, but I had an element of doubt. This did not look like a vesicle to the clinician's eye. So I took the history once again, and a very funny, surprising thing came up that this photo was taken soon after the bath. And those were drops of water still on the body. So I saved myself from landing with a misdiagnosis of vesicular rash. This was a plain and simple perifollicular rash in a patient on home isolation. This is erythema multiforme. This we had seen from another patient in home isolation, but not from our hospital. It's from somewhere else outside Lucknow. And erythema multiforme can have its presentation once again because of the virus, due to the drugs which is being given, or totally unrelated event. This rash is very commonly seen. People often keep on harboring these rashes for a long time, but they come up with this rash when they are after they have been diagnosed with COVID, when they pay attention to their entire skin. This is a very common tinea which has started to regrow in this humid condition. And this one is a true vesicular rash. The third pattern. This did not conform to any particular pattern, and we did a conservative management for this. Yet another vesicular rash, which we commonly see, although this one was seen in COVID patient, but this was actually a case of herpes zoster coexisting during COVID positivity. And yet another patient, this patient had been released from treatment of COVID, went home, and about a week later, this patient presented with these rashes. This is herpes zoster once again. This is enanthem, mucous membrane, very commonly informed, erythematous rash. Again, a non-specific rash, does not go on to provide any much help in diagnosis. So far, I've been talking about the acute viral phase, in which all the rashes are such that they can be seen in all other viral infections also, and in other conditions which may present with such. Similarly, the treatment also depends on the symptomatology, and they are usually self-limiting. The second and the more interesting phase that has come up in COVID times is during the second phase, or the phase of immune dysregulation. Here we come across petechial or purpuric rashes, and then pernio-like lesions, and also livedo reticularis. The pathogenesis is yet to be well defined. Lot of hypotheses are going on. The most acceptable one is the COVID-associated coagulopathy. But in itself, this alone is not able to explain all the three variants of the lesion. So in this condition, the controversy is there that whether these are at all directly the result of the infection, the immune dysregulation, or totally unrelated event. Like in the West, they are saying that it is more because of the quarantine and limitation of movement that has led to the pernio-like lesions in those cold places, cold countries. But this hypothesis is yet to be accepted. These are the petechial rashes. This one, the purpuric. And the most discussed, hotly debated, and some even say this is diagnostic of COVID-19. As of now, amongst dermatologists, this has not been established that this is a diagnostic sign of COVID. But one thing is well understood, that although it is the result of coagulopathy, this usually is not seen in patients with severe illness, nor does it signify a very poor prognosis. So far, none of the patients who had presented with these lesions have gone into a critical level. Yet another one just started. This one involving more than one toe. They start uniformly as small reddish erythematous papules, and they gradually change in color and become dusky red, and then further darken up, usually associated with some amount of itching, may be tender and painful. And then the third pattern, which is commonly seen, is the livido reticularis or racemosa. Here also we see the lace pattern on the back of the thigh, the legs, here around the shin, along with some perifollicular lesions. So the previous three patterns, which is seen in the dysregulation of immune system phase, they are separate from the other viral infections, and they are not seen in most others. And these are the conditions which are still being put under various hypotheses, and we are yet to understand why these happen. In the third phase, that is the recovery phase and the convalescence, which overlaps onto the post-COVID sequelae, we come across two other important and bothering presentations. One is the acneiform eruptions, which is being strongly correlated with the use of steroids. The duration and the dosage of the steroid that has been used in the more severe condition directly responds, or rather presents, with the severity of the acneiform eruptions which develop later on. One good thing with this particular thing is because the steroids are stopped, the condition does not progress beyond a certain period and usually resolves with minimal treatment topically. At the same time, the most bothering skin condition, rather the hair condition, develops, and that is telogen effluvium, diffuse loss of hair from the scalp, which is more than normal amount. This is multifactorial, starting from stress to disturbed diet, which has its own implications, and the patient, after recovery, feeling very happy that survived COVID, is now bothered with this hair loss, telogen effluvium. So these are the skin presentations which we need to tackle on a day-to-day basis whenever we come across such cases. Overall, the management and treatment is only under two headings: symptomatic, as and when the patient presents. If it is urticaria, antihistaminics, maybe a bit of steroids. If it is one of the erythematous rash, hygiene is the most important thing. Antipruritic may be used if it is symptomatic. In those with COVID toes or with purpuric rash, one should pay attention to the coagulopathy. Otherwise, they in themselves are self-limiting. Acneiform eruption, as I said, that is also self-limiting and responds very well to topical treatments. And telogen effluvium takes time, but that also improves in about 3 to 6 months. The rest of the treatment is done as per the prevailing protocol for management of COVID-19. This is one thing that I came across while preparing this particular presentation. Although a whole lot of things were there, variable from Europe, from America, this CMAAO, this is the Confederation of Medical Associations of Asia and Oceania, which includes about 19 countries from our region. Here, every week, I believe, the meetings are held. Nowadays, it's all virtual meeting, and they keep on giving advices. So at that time, I came across this particular thing, and they brought into limelight that the virus is present in skin, and this had been published in Lancet in a case which was very unique, that the RT-PCR was negative, but the skin biopsy samples from rash were positive for the virus. In the same discussion, few more things were there, which although unrelated to skin, were very interesting. And that was for me a learning experience, that COVID-19 virus has 6 antigens: ESN, ORF1A, ORF1B, and RDRP antigen. E antigen is common to coronaviruses, all of them. If negative, no coronavirus, and the rest 5 are specific for COVID-19. So we need to do more than one test. RT-PCR tests the antigen. If only one antigen is tested, the sensitivity is low. Testing for 2 or more antigens incurs higher costs. I understand presently the E antigen is first being done, and if it is positive, one of the other 5 is done to confirm. One more fact that I came across and would like to share is that the virus becomes non-replicable inside the body after 9 days. But we need to find out how long these antigens remain inside the body, which we test. And then some more information that the patient is non-infectious under following conditions they had defined. Demonstrates the presence of IgG antibodies. The titer is also important, with or without presence of antigen. And the patient is asymptomatic for 10 days, and the patient was positive 2 weeks earlier. His ESR and CRP are normal. Probably we are following these. And just to harp on the old thing, masking and social distancing, they also harped on this, that it is very important. And one thing that is important for me, maybe for some of you, that cold and frozen food, the virus can survive for much longer. Someone like me who loves non-veg, getting it from the shops, fresh, and then storing it in the refrigerator, I don't know. I am skeptical about it. Thank you.